So I'm going to go through the PowerPoint that kind of talks more about the conditions first, and then her PowerPoint and recording is about 25 minutes. So then we'll watch together, hopefully, if the sound works and everything. If there's something going wrong and I play it and you guys can't hear her sound, then I'm not going to play it. You'll just have to watch it on your own. But hopefully it'll work and it'll just all be cohesive. So then you can watch this Zoom class and you'll see this part and then Dr. Bradley's part together. And we might get done a little bit early, we'll see. Okay, so I'm gonna pull up the PowerPoint for this week. And if you guys, I always lose your chat. So if anybody has a question or anything, just unmute and just ask me, because I can never see what's going on in the chat for some reason when I'm doing this. But okay, so this week is neurologic disorders. So we're basically talking about 3 conditions, which is nice. It's not like this endless list of disorders. We're going to talk about Alzheimer's, Parkinson's disease, and epilepsy. And then in our guest speaker's presentation, she talks a little bit about neuropathic pain. And I thought that that was in this one as well. So I had written it, oops. So I'd written it down here at the bottom, discuss neuropathic pain. But then when I got to the end of the PowerPoint, I realized it wasn't there. So, but it's in, she talks a little bit about it and with medication. So these are the objectives for today. And so the first part of this, let me move this over here. The first part of the presentation is a little bit of review. We'll talk about like neurotransmitters and the process of what neurotransmitters are doing, and this is kind of a nice review for what we've already been discussing. So we know that we have the central nervous system, we have the peripheral nervous system. Your central nervous system is just your brain and your spinal cord, so it's centered, you know, kind of central controls. It's like the main control area for everything. And then we have the peripheral nervous system, so it innervates everything other than your brain and, you know, your spinal cord. And then we know that that's divided into our autonomic, which is involuntary, and then our somatic nervous system, which is voluntary. And then of course we talked a lot about sympathetic and parasympathetic. So basically the first part, so since we're reviewing this, the nervous system and neurotransmitters, we want to think about how an imbalance or something not functioning properly with neurotransmitters, how they can negatively affect brain movement, learning, all kinds of stuff. And so they're going to directly be correlated with these conditions that we're going to be talking about here. So if you remember, neurotransmitters are chemicals that enable our neurons to kind of talk to one another and initiate or continue the initiation of an action potential. So the neuron that is before the ganglion, this is the ganglion, this little area right through here. Am I pointing in the right area? I hope I am. If you guys can see that. So this is that's the ganglion. So the neuron that comes before it is called the preganglionic neuron. The neuron that comes after this ganglion is the postganglionic neuron. So just to orient, and then this area right in between where the neurotransmitters go floating from one side to the other. I think it says it in a video that we'll watch, but they're not physically touching. Like these neurons are close, but they're not physically touching, but they're so close. They're like closer than the width of a piece of hair. Like it's like they're so close, but you can only see that they're not touching under like a, you know, microscope, like way. But this little area is called the cleft. It's like the synaptic cleft in between the space where the neurotransmitters go from one side to the other in this area called the ganglion. If I'm talking too fast or you want me to repeat something, just let me know. So to recap, what do we need to know about neurotransmitters and what do they do? So neurotransmitters are synthesized and stored in the neurons, and more specifically, they're stored in what's called vesicles in the axon terminal. So if I go back to here, this little area right here is an axon terminal. So that part of this system, that's the ganglion, this is the axon terminal. And that's where the neurotransmitters are basically synthesized and stored. And there's a better picture. I think we'll watch a video that shows these little vesicles that hold the neurotransmitters until they're ready to be released. So an action potential initiates the release of the neurotransmitters, and they're sent over the synaptic cleft, that little gap, to the postganglionic neuron to continue that action potential. So whatever is supposed to happen, it's kind of initiates the release of the chemicals. They hop over, they bind to the receptors, and then that enables them to have talked to the other side to continue that action potential. So more neurotransmitters are released. Now on the other side, closer to your target organ, whatever you're trying to accomplish, whatever the body's trying to accomplish, that action potential goes down that second neuron, more neurotransmitters are released, and then now we finally have either an inhibitory or an excitatory effect. So either something is being, from that whole action potential, that whole process is either inhibiting something or exciting something to happen. So far, we've talked about so the neurotransmitters that we might be familiar with, because we've talked about them already, are acetylcholine, ACH, norepinephrine, NE, and epinephrine. Those are the three that we've kind of probably talked the most about, I feel like, so far, if I'm remembering right. And then the ones that we're going to talk more about today and learn a little bit more about today, dopamine. I have no idea why serotonin is in there. I meant to take it out because we actually don't really talk about serotonin. But what we do touch on that's not in here is glutamate. So if you want to make a little note somewhere, you can cross out serotonin. It is a neurotransmitter. We just don't really talk about it today. And you can put in glutamate. And then GABA. We also talk a little bit about gamma aminobutyric acid. So dopamine and GABA, let's see, I think that's on my next slide where we talk about it a little bit more into detail. Hold on. Okay, so here's a close-up of the synaptic cleft. So this little gap here between this is the axon terminal, and then this is the other side of the ganglion. I feel like there's a name for it. I'm sure there is. It's just escaping me. But this little cleft is the synaptic cleft, and then this whole system here with the two parts is the ganglion. So I'm going to go to this video, and I'm really hoping you can hear it. If you can't hear it, somebody tell me right away.
That face that is usually covered by our phone has finally made an appearance. Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes. In this installment, I will discuss synaptic transmission. Most communication between neurons occurs in a specialized structure called a synapse. Synapse is an area where two neurons come close enough to one another that they are able to pass chemical signals from one cell to another. The neurons are not actually connected, but are separated by a microscopically small space called the synaptic cleft. The cleft is less than 40 nanometers wide. By comparison, a human hair is about 75,000 nanometers wide. The neuron where the signal is initiated is called the presynaptic neuron, while the neuron that receives the signal is called the postsynaptic neuron. In the presynaptic neuron, there are chemical signals called neurotransmitters that are packaged into small sacs called vesicles. Each vesicle can contain thousands of neurotransmitter molecules. When the presynaptic neuron is excited by an electrical signal called an action potential, this causes the vesicles to fuse with the presynaptic membrane and release their contents into the synaptic cleft. Once they are in the synaptic cleft, neurotransmitters interact with receptors on the postsynaptic membrane. They bind to these receptors and can cause an action to occur in the postsynaptic cell as a result. This action may involve increasing the likelihood that the postsynaptic cell will become activated and fire an action potential, or decreasing it. Eventually, the neurotransmitter molecules must be cleared from the synaptic cleft. Some of them will simply drift away in a process called diffusion. In some cases, the neurotransmitter is taken back up into the presynaptic neuron in a process called reuptake. Once back inside the presynaptic neuron, the neurotransmitter can be recycled and reused. In other cases, enzymes break down the neurotransmitter within the synaptic cleft. Then the component parts of the neurotransmitter can be sent back into the presynaptic neuron to make more neurotransmitter.
Okay,
Welcome to 2-Minute Neuroscience.
now to get back to where we were. Okay. I thought that bit at the very end where he showed that little yellow rectangle where it can be reuptake, the neurotransmitters can be reuptaken. That's the wrong word, but it reminded me, I thought, oh, that'll come in handy when we're talking about drugs like SSRIs, the serotonin reuptake inhibitors. So that made perfect sense then. It was like, oh, it's stopping that part of the neuron from taking up, recycling the serotonin. So I thought that was kind of interesting. That'll make more sense when we talk about that chapter. But anyways, so that was a good little review on how they travel across from one neuron to the other. Okay, so dopamine, so this is one we haven't talked a ton about. So it's a very important neurotransmitter in the process of movement. So there's a couple things that you're going to want to really star for the exam. So you want to think about when we think of specifically for Alzheimer's, or when we think about Parkinson's disease, we want to know, kind of star these for those conditions. So think of, when you think of a patient with Parkinson's, just automatically connect dopamine. There's an issue with the dopamine. So we'll see this play a significant role when we talk, you'll see it a little bit more when we talk about Parkinson's in a few minutes. But acetylcholine is involved in peripheral nervous system. So it's skeletal movement, regulation of smooth muscle, and cardiac muscle. So we've talked about acetylcholine when it comes to smooth muscle and cardiac. We kind of are familiar with that, but we haven't thought about it so much when it comes to skeletal muscle movement. But acetylcholine is also plays an important role for that. So acetylcholine also is very important in the central nervous system in regards to learning, memory, and mood. So if something is important, memory should kind of trigger your immediate recognition to what possible condition could that play an impactful role. Alzheimer's. So when we think of these, we want to automatically kind of have those, like, star those areas, because those will be test questions, is knowing the relationship between acetylcholine and learning, memory, and mood, and Alzheimer's disease, or dopamine, muscle movement, Parkinson's disease. So these kind of things, you kind of want to connect those things together. So in a healthy person, acetylcholine and dopamine are balanced, they're well balanced, but when one is deficient or excessive, then the balance gets thrown off. And that's when you start to see disease symptoms. So we'll talk about more about what that reveals when we talk about the diseases here in a minute. So two neurotransmitters that we've already really haven't discussed are GABA and glutamate. So GABA inhibits the presynaptic release of other neurotransmitters. So it's kind of like a pre-neurotransmitter. It kind of regulate it. It kind of has to do with what's gonna what's going to be happening in the next step. And then glutamate is a major mediator for excitatory signals, so exciting the neurons. And basically, if you think about, I kind of think about something like getting really hyper and bouncing all around, and then it just gets more and more excited and more excited, and then it like blows up. So like I have this little cartoon in my head. So when you think of glutamate, too much of something that's excitatory can actually be toxic to the neurons, and it can actually kill the neuron. So when I was growing up, my mom's kind of a health nut, and so like she would always say aspartame is a neurotoxin. It's a neuroexcitatory toxin. And so when I read this, I'm like, oh, I remember that, because I know like aspartame is not good for you because it's a neurotoxin. Or has anyone heard of like people who can't take monosodium glutamate, MSG? That might be like, I can't eat food with MSG. That's monosodium glutamate, and it's a neurotoxin. It excites the neuron. So I can kind of think glutamate, too much glutamate, bad for neurons. It kind of just clicks in my brain because I think about hearing what I've heard in the past. So if that helps. Okay, so we'll discuss Alzheimer's first. We'll discuss Alzheimer's, Parkinson's, and epilepsy for the neurologic disorders, but we'll go into Alzheimer's first. So Alzheimer's is predominantly age-related. However, there is early onset Alzheimer's, although it's less common. I remember having a patient when I worked for Dr. Matsuda, and he was like, late 40s, and he had early onset Alzheimer's. And I saw him for, almost 5 years, and just that deterioration, but he had teenage kids, and it was a very heartbreaking condition when it's any age, but especially when it's early onset. Alzheimer's is characterized by memory loss, decline in abstract thinking and judgment. Essentially, what's taking place is there's a loss or there's a deterioration of cholinergic neurons. So when someone has Alzheimer's, one thing that's happening is their cholinergic neurons, they are either losing them, they're just like breaking down and dying, or deteriorating, which is essentially going to lead to the same thing. So acetylcholine is lost. So acetylcholine is going to be one of the main neurotransmitters in the cholinergic neuron. So they're losing acetylcholine, and they seem to be getting too much glutamate. It seems to be increasing, and glutamate can be toxic and kill neurons. So what we want them to have is the acetylcholine that seems to be going away. Glutamate seems to be increasing. So let's watch this video here. It's going to be a lot of information that we don't need all of it, but it'll kind of, it says a few things that'll really zone in on what is important for you guys to know for like exams and stuff. So let me see if I can pull this up. So this is, if you go to here, this is an NIH overview, National Institute on Aging, what is Alzheimer's disease? So you can read stuff here. It's a really good overview, but they have this video. If you scroll down, they have this video here that we'll watch this. I think it's about 4 minutes.
In healthy people, all sensations, movements, thoughts, memories, and feelings are the result of signals that pass through billions of nerve cells or neurons in the brain. Neurons constantly communicate with each other through electrical charges that travel down axons, causing the release of chemicals across tiny gaps to neighboring neurons. Other cells in the brain, such as astrocytes and microglia, clear away debris and help keep neurons healthy. In a person with Alzheimer's disease, the most basic form of dementia, toxic changes in the brain destroy this healthy balance. These changes may occur years, even decades, before the first signs of dementia. Researchers believe that this process involves two proteins called beta amyloid and tau, which somehow become toxic to the brain. It appears that abnormal tau accumulates, eventually forming tangles inside neurons. And beta amyloid clumps into plaques, which slowly build up between neurons. As the level of amyloid reaches a tipping point, there are
Sorry, I just wanted to pause it right there because that's one thing. Sorry, this is in the way. I don't know if I can get rid of it. I just wanted to pause it there because plaques and tangles is something that you'll hear. So this is the plaques building up from the beta amyloid, and tangles inside all these little blue things. That's the protein, whatever that other, the tau protein, it builds up like a tangle. So when you think of what's happening with an Alzheimer's patient in their brain, there's a buildup of plaques and tangles. So I wanted to pause that so you could see that visual and remember that that's an important thing to remember.
There is a rapid spread of tau throughout the brain. But tau and beta amyloid may not be the only factors involved in Alzheimer's. Other changes that affect the brain may also play a role over time. The vascular system may fail to deliver sufficient blood and nutrients to the brain. The brain may lack the glucose needed to power its activity. Chronic inflammation sets in as microglial cells fail to clear away debris, and astrocytes react to distressed microglia. Eventually, neurons lose their ability to communicate. As neurons die, the brain shrinks, beginning in the hippocampus, a part of the brain important to learning and memory. People may begin to experience memory loss, impaired decision-making, and language problems. As more neurons die throughout the brain, a person with Alzheimer's gradually loses the ability to think, remember, make decisions, and function independently. Achieving a deeper understanding of the molecular and cellular mechanisms and how they may interact is vital to the development of effective therapies. Much progress has been made in identifying various underlying factors. Advances in brain imaging allow us to see the course of plaques and tangles in the living brain. Blood and fluid biomarkers are providing insights about when the disease starts and how it progresses. More is also known about the genetic underpinnings of the disease and how they can affect particular biological pathways. These advances enable the development and testing of promising new therapies, including drugs that reduce or clear the increase of tau and amyloid proteins in the brain, therapies targeting the vascular system, glucose metabolism, and inflammation, and lifestyle interventions like exercise or diet.
I think that might be the crux of it. I don't know that we have to watch the rest. You guys can always go in here and watch it too. Okay. So another point though, so the plaques and tangles are important to be aware of. Blood flow impairment is also another one, but ultimately the dying of the neurons is a big take-home point there. So, and then the brain shrinking. So those are some big take-home points from that video that I wanted you guys to see. Okay, so the next slide. So generally the cause, although they're starting, you can, when you read a lot about this, you can read about like some genetic components, some lifestyle. There's studies that call it like type 3 diabetes. Like they're finding more and more out about it and why certain people are more predisposed to Alzheimer's disease. But in general, the overall statement is still that it's kind of unknown, even though I feel like you can't deny some lifestyle, you know, some things that might be pointing toward lifestyle, but they haven't come out with saying this causes this. So it's largely still unknown. Some environmental factors that they have found a correlation to is exposure to some heavy metals, aluminum, mercury, and then they say viruses, but it's really not proven. It's more like a hypothesis. So it's that's still kind of up in the air as well. So early signs and symptoms of Alzheimer's, they literally changes can be happening in your brain up to 20 years before you have outward symptoms. So it's very hard to do any kind of early prevention or something, because somebody could live decades before something shows up, which is kind of frustrating and scary. But it includes memory loss, confusion, loss of language skills. Later on, individuals will not be able to hold down like a job. They'll get confused easily. They'll need regular supervision. In the advanced stages, they're going to lose all ability to communicate, very rigid body, incontinence, and then basically they'll be bedridden. So for an exam question, be sure that you know the difference. If there might be a question that says like your patient comes in and they're doing this, this, and this, what stage of Alzheimer's might they be in? Early, middle, or late stage. So make sure you know those markers for the different stages. Okay, so drug therapy for Alzheimer's disease is fairly kind of difficult to manage in some ways. The pharmacy, our guest speaker of pharmacy, will talk more about the drug therapy. But if you were a drug, you want to kind of think about, if you know about what's happening with the acetylcholine and the fact that acetylcholine seems to be going away and glutamate seems to be coming. If you were a drug, what would you want to be doing? How would you want to work to be more effective? So you would want to make sure possibly that acetylcholine stuck around, right? You would want to decrease the breakdown of acetylcholine in the synapses. You would want to try and inhibit the enzymes that break down acetylcholine so that it sticks around and it's more available. So just kind of, if you tell yourself a story about what's going wrong, and then that will help you remember the mechanism of action of some of the drugs that are there to, either slow the process or reduce symptoms. So in Bridget's video, she shares with us that it's proposed that the degeneration of the cholinergic neurons in the basal forebrain and the associated loss of the cholinergic neurotransmitters in the cerebral cortex, those are the areas that's contributing significantly to the deterioration of cognitive function. So that's what they're trying to slow down basically with the Alzheimer's medication, is to try to prevent acetylcholine from going away so easily, or from it being broken down and not being available for the brain or for the neurotransmitter. I just totally lost my train of thought there for a second. Okay, so any questions on Alzheimer's? No? Okay. So we will move on to Parkinson's disease. So Parkinson's is also another age-related disease. However, just like Alzheimer's, it can have an early onset. So if you guys maybe are familiar with the actor Michael J. Fox, he's more from like the 80s and 90s, Back to the Future movies. He disclosed in 2000 that he had early onset Parkinson's, or young onset Parkinson's disease, but he actually was diagnosed in 1991 when he was 29 years old. And typically we think that's, you don't see very many young people with Parkinson's. You do generally think of it as something that's age related, but just like Alzheimer's, it can have an early onset or a young onset. So Parkinson's disease is chronic, it's progressive, meaning it gets worse as time goes on. It's a degenerative disorder of the central nervous system. So here in this picture, you can see a healthy patient. You can see there's lots of dopamine going from the vesicles down to the receptors, from the being released from the vesicles down into the receptors. It's funny because this drawing looks different than how I would have drawn it. But anyways, but in a patient with Parkinson's disease, there's not a lot of dopamine. So just, connect again, dopamine, Parkinson's disease, and that will kind of start to, you just get those things together in your mind. Okay, so the initiation of muscle movement. So when we think of Parkinson's disease, we think of older people who we'll talk about their symptoms, but they have tremors, they're rigid, they have shuffling walk. It's like movement, right? Their movement is impaired. So we want to know like what's going on there. So the initiation of muscle movement happens in the pyramidal system. I'm probably saying that wrong. pyramidal system. And that is where your movement is initiated. And then muscle movement is controlled in the extrapyramidal system. So what's happening with a person with Parkinson's disease is because they have decreased levels of dopamine, whatever they're going to do in that extrapyramidal system to regulate how your body controls movement, it's not happening. There's a negative effect there because of the decreased amount of dopamine. So patients don't have as much control of their muscular movement. So they sometimes, when they're doing some kind of a big gesture, it actually sort of helps that fine shaking or that fine kind of warbling of their body when they're trying to do something really small. But when they do something like a bigger movement, it temporarily gives them more stability. So it's kind of interesting. Michael J. Fox, in a video, I think I'll show it, it was saying how when he does something big like ice skating, he doesn't have all his little tics, but when he's trying to do something little, that's when it really shows up. So it's kind of interesting how it's like shifts different areas of the brain that are controlling the muscles. But in general, decreased dopamine is the main crux of what the problem is for a patient with Parkinson's. Here's a picture of the area of the brain that is really where it's sort of the central area where this is happening, and it's called the substantia nigra. And you can see in the top video here, oops, sorry. In the top picture here, this is like a healthy, normal substantia nigra. It looks full, whereas down here below, it looks more atrophied. So it's just shrinking and it's just not doing its thing. So there's some atrophy going on there. So the etiology, again, unknown. They have some, again, I think there's some lifestyle things that are suspected or genetic perhaps, but in general, it's still unknown what triggers it or what starts it. People can have other Parkinson-like symptoms after a stroke or brain tumor, head injury, or exposure to some of these things down here, manganese, mercury, carbon disulfide, and street heroin. So there are other things that can sort of lead to Parkinson-like symptoms, but in general, the actual cause of what triggers it in one individual to the other isn't really understood. So when you think of a Parkinson's symptoms, think of TRAP, T-R-A-P. That's T for tremor, R for rigidity, A for akinesia, but we a lot of times will say bradykinesia, which is basically just like slow movement or like difficulty with movement. Kinesia being kinetics, movement. But that's what the A is for, is akinesia. Under that bradykinesia or akinesia, there's the masked, they call it a masked face, because there's just not a lot of expression. There's not a lot of muscle control, so there's not a lot of expression. And then also with that akinesia, there's the short or the shuffle step. They just can't take these big strides, so there's like this little shuffling. And then the last one, the P in the TRAP, is postural instability. So they're going to be easily off balance, falling is common, poor posture, kind of slumped. So those, what do you call that, an acronym? Is that what it is? TRAP would be an acronym for, I don't know if I'm thinking of the right thing, but anyways, that's what you want to do. Think of TRAP. Okay, here's another video. I can't remember what this one is. This might be Michael J. Fox. Oh, it is.
Was a film that helped define the 1980s and made Michael J. Fox a star. More hit movies followed, as did a string of awards for his TV series like Spin City. Now, though, his future's increasingly defined by Parkinson's disease.
As soon as I wake up, I can't go back to sleep. I mean, it starts going. So I would say that's the toughest part in the morning is to kind of go, well, I'm up whether I like it or not, I'm up now. And the other thing that happens to me in the morning, first thing is I get that dystonia, which is kind of cramping, and it can be very extreme.
In a rare interview on ABC, he spoke about the new challenges from something as simple as using a toothbrush.
Because I put the brush down on the countertop, hold it flat, and get the bristles on, because if I hold it, I miss it. It's a moving target. But anyway, once I get all loaded up, then I just gotta bring it up to my mouth and then just let it go.
Remarkably, he also revealed that ice skating appears to temporarily block his symptoms, but only while he keeps moving. There's no cure for Parkinson's, but Michael J. Fox has been fighting to change that. He's gone from actor to activist, campaigning for politicians backing stem cell research, which might offer hope to Parkinson's sufferers. Millions have seen the powerful TV campaign he made a few years ago.
They say all politics is local, but it's not always the case. What you do in Missouri matters to millions of Americans. Americans like me.
Michael J. Fox returns to ABC.
He devotes much of his life now to raising awareness about Parkinson's, and after many years off the big screen, he says he still watches his old life on the small screen.
At any given moment, I can flip through the channel and see myself, and for a long time, it was just like I stumbled on an infomercial or something and just keep clicking. But now every now and then I will stop and watch it a little bit, and I'll just enjoy it. I'll just enjoy it for what it is and the time it was in my life, and I don't have any. There's no wishfulness in it. There's no longing.
Richard Lister, BBC.
Okay. Oh no, that's not the right one. There we go. Okay, so it's interesting because I've had a lot of older patients with Parkinson's, and he has kind of more of like almost like a rolling movement with his body, whereas a lot of older patients have a lot of their speech can be very slurred, and there can a lot of trouble swallowing. So we have to be very aware of those things when we have a patient in the chair, and then lots and lots of shaking, like this kind of tremoring, whereas his, and maybe it's because his is a young onset, so it kind of manifests itself a little bit differently. Yeah, I just thought that was interesting. So, okay, so next slide. Okay, so there's no cure for Parkinson's. They said that in the video. The goal is to reduce the symptoms, to restore the balance between dopamine and acetylcholine. And I don't think we really, I don't think so far we've gone into why that imbalance is causing the symptoms. So I think that must be in the slides coming up. But this is accomplished by either increasing the activity of the dopamine, so that would be some kind of an agonist medication that like increases activity of the dopamine, or by reducing acetylcholine. So the anticholinergic drugs might be something that is also used, or maybe both. Maybe they're used together. But when a patient's on an anticholinergic drug, what would be something that they may experience? Do you remember another, I can't think of the word, but what's the other phrase that SLUD, remember, another acronym that patients experience when they take anticholinergic medications? So they have reduced saliva, reduced lacrimation or tearing. They have reduced urine production and defecation. So if you have an Alzheimer's patient, there can be drooling because they can't swallow, but it's not because they have excessive saliva. It's because of more of the drooling aspect. They might actually have dry mouth, which is kind of weird to think of both of them together, but they might have a diminished amount of saliva. It just pools in the area, but it doesn't go down their throat. Okay. So finally, we will talk about epilepsy. So epilepsy is a relatively common condition, 1 in 200 individuals being affected. That's per the text. So that might be a slightly different number because the text is a couple of years old. It's defined by excessive discharges of brain neurons and charges in the electrical activity in the brain. Epilepsy causes seizures, altered consciousness, and or involuntary movement. It can happen in just part of the brain. They call that a focal seizure when it's just part of the brain, or it can happen in the entire brain, which they call a generalized seizure if it's the whole brain. A simple focal seizure is one where the individual does not lose any consciousness. They stay awake. They might just kind of stare off into the distance. Children can have these where they just kind of like zone out for a minute and then come back, but they don't lose consciousness. A complex focal seizure, they do lose consciousness. So if it's just part of the brain, but it's complex, it's like a bigger or something bigger is happening, then they can black out, lose consciousness. A general seizure is divided into two categories, absent seizure, or what they used to call petit mal, or tonic-clonic, which they used to call grand mal. So it used to be petit mal, grand mal, but now it's absent seizure or tonic-clonic seizure. Then there's also the unclassified status, I always want to say ellipticus, but I say it wrong, epilepticus. And that is more of a medical emergency. That is somebody who has a seizure that lasts more than 5 minutes. Sometimes they'll say up to 20 minutes. You'll see it in the medical emergency stuff. They'll be like a seizure that lasts more than 20 minutes. But they say if somebody has a seizure and it's going on for more than 5 minutes, call 911. Or if they fail to recover from the first seizure and they go into another seizure, that's not just your tonic-clonic. That's something more that you need to get EMS for that. So about half the cases, they're not sure why it happens. Sometimes children grow out of it. The risk factors: trauma, infection, fever, kidney failure, recreational drug use, could be developmental, hypoglycemia. Someone could go into a seizure from hypoglycemia, or it could be a hereditary or a genetic thing. So there's different risk factors for seizures. So a tonic-clonic seizure is the most common type of seizure for all ages. Star that. That'd be a question that'd be a good exam question. So tonic-clonic seizures are the most common type of seizures in all ages. Individuals may experience an aura, which comes right before the seizure. This could be like a smell, a taste, a feeling, lights, like it could be all kinds of things. You could hear what they call the epileptic cry, which is when everything contracts and all the air is pushed real fast out of the lungs. And then there's like this, crying, yell or whatever. And then the tonic phase is when the whole body contracts. So everything, neck arches, back arches, fingers clench, everything comes in a contraction. And then the clonic phase, there's a kind of a rhythmic, not necessarily coordinated relaxing and contracting of the body and the muscles. So I think this is my last, hold on, let me just skip to this. Before I play this video, this is the last video in this thing, but I'm just going to show you. So medical complications of seizures, obviously head and neck trauma, but also biting tongue, biting the lips and cheeks, injuring their teeth if they fall and have a seizure, but they fall and hit their face or something. And then aspiration pneumonia, if they have something in their mouth, or if they vomit or something and then aspirate that, so that can be dangerous as well. And then one of the biggest things you guys have to just star is phenytoid or dilantin. That causes gingival hyperplasia, and that's a very common side effect. And just anytime you think of seizure medication, just have that be the first thing that comes to your mind. It's phenytoin or dilantin, and it causes gingival hyperplasia. And we'll see more about it in the video, but just big star. You need to know that for board questions. Love it. It'll be on your exam, I'm sure. So let's just see this video real quick, and then we'll take a break. Oh, wait, hold on. Oh, it did the right area.
Yeah, but no, I was doing video games. You were playing video games. Excuse me, ma'am. Can you please pass me my sweater and my bag over there? It's okay. Sure, what happened?
You have epilepsy.
Should I call 911?
No, and it's okay. It's not an emergency.
Well, is he gonna swallow his tongue? Are you supposed to put a spoon in his mouth or something?
Honestly, if we put anything in his mouth right now, he's gonna either choke or he's gonna break his teeth on it. The best thing we can do is just wait it out. We just gotta make sure he's safe and there's nothing around him where he can harm himself. Okay. Just breathe. I'm here.
Okay. Okay, so let me stop sharing. We can take a break. What time is it now? So it's basically 2:10. Let's take maybe like 7-minute break, and then we'll come back and we'll watch Bridget's video. Sorry. Okay.
First disease, Parkinson's disease. We'll briefly touch on seizures as well as neuropathic pain. We will focus on the most common medications used in these disorders. So there will be many other medications that you might see on a patient's medication list, but the ones we'll cover in this presentation will kind of be the gold standard or the hallmark medication. So hopefully we'll be able to identify the common adverse effects and some potential specific oral implications. These are all the medications for the top conditions we'll talk about. Alzheimer's disease, we have 2 medication classes, the cholinesterase inhibitors, and the one we'll focus on is donepezil, and then the NMDA antagonist, and the one we'll focus on there is the only one in the class, which is memantine. For Parkinson's disease, there's a number of medications which you'll see that they're all trying to increase dopamine. So we have our dopamine precursors, which is levodopa, which you'll see is always given with carbidopa to prevent the breakdown. There's dopamine agonists, so we'll look at ropinirole and pramipexole. There's the COMT inhibitors, so we'll look at entacapone, the MAOB inhibitors like salicyline, and then anticholinergics. For seizures disorders, we'll look at carbamazepine, phenytoin, and valproic acid. And then for neuropathic pain, gabapentin and pregabalin, which can also be used in seizure disorders. I believe this may be a bit of a review for you guys about Alzheimer's disease and how it develops, but it is a progressive neurodegenerative disease. 72% of all cases of dementia in people over 75 years old in the US. And the concern, or how Alzheimer's disease develops, are these plaques and tangles. And there's destruction of the cholinergic neurons. And so you'll see that the medications that we use to address the symptoms of Alzheimer's disease is really focusing on increasing the acetylcholine. As I said previously, Alzheimer's disease is a progressive disorder. The early stage of Alzheimer's disease, or the mild stage, patients may have very mild symptoms that really wouldn't be maybe even noticeable to the patient.
Leslie, we can't hear anything.
There's also more trouble in remembering and organizing, and then this can develop over 2 to 10 years. Late stage Alzheimer's disease, or severe, this is when there's going to be an increase of those plaques and tangles and more loss of neurons. Now patients are not going to be able to communicate. They may not be able to participate in activities of daily living. And this is when patients would routinely need a higher level of care than what maybe a family member can provide to them. There are a number of early signs and symptoms of Alzheimer's disease. And so in the one column, you'll see the signs of Alzheimer's disease, and then it is compared to typical age-related changes. So you'll see in Alzheimer's disease, they have memory loss that disrupts their daily life, where a typical age-related change may be sometimes forgetting names or appointments, but remembering them later. So you can see that in Alzheimer's disease, all those listed in this column would highlight the difficulty in the patient being able to care for themselves, where they may need additional assistance, where typical age-related changes, they may get confused, but they'll remember it later. Other symptoms may be related to vision changes related to cataracts or something. And so there's 5 listed on this slide, and then there's additional 5 listed here. So this was from the Alzheimer's organization, and they list out the 10 signs of Alzheimer's disease. So there is no cure yet for Alzheimer's disease. There is a lot of research, so there's new blood tests in development to diagnose earlier. There's also many, I think I found 3 or 4 studies looking at the prevention of Alzheimer's disease, and some of those results are expected later this year. So that's promising. And many of those prevention trials are looking at drugs that could stop the formation of the plaques and tangles. But currently our drug therapy is targeted at treating the cognitive symptoms. So again, we're looking to increase cholinergic activity through our cholinesterase inhibitors and reduce early neuron death, and that's our NMDA antagonist, or memantine. There's also other areas we target. So as Alzheimer's progresses, patients can have depression, agitation, anxiety. So we would use the same medications that we use for those disorders as we would without Alzheimer's disease, as we would in Alzheimer's. When we're treating these conditions in a patient that may also have Alzheimer's, we're just going to be really considering the age, so we're not putting the patient at risk for age-related medication concerns like falls. There's also some evidence that cardiovascular and metabolic disease could play a role in the development of some types of dementia. So we would also be targeting and making sure that we're controlling blood pressure, cholesterol, as well as diabetes, or their blood sugars. Our first drug class are the cholinesterase inhibitors. So they are decreasing the breakdown of acetylcholine, allowing more acetylcholine to be available so that hopefully those neurons are firing as they should. The one that we'll pay attention to is donepezil, or the brand name is Aricept, but you see the other 2 listed as well. The concerns with these medications is that the nausea and vomiting can be profound, and usually is dose related. So usually patients will start on a really low dose and then increase it over time. We also can be concerned about dizziness, so there is a fall risk for these medications. So we do want to be careful when the patient has been laying down or sitting for a long time, that we make sure that they're getting up slowly so that they're not in an increased risk of fall. The other medication class for dementia is the NMDA antagonist, and that is memantine. You see it listed. This one, again, can cause dizziness, so we just want to be careful when a person goes from sitting to standing. For our patients with dementia, they can have declining oral health, and this may be because they're unable to care for their dental health needs, or they may not want acceptance of help from other in supporting their oral hygiene. So that's something to consider for these patients. There's also risk of oral and dental disease due to altered salivary flow. Their taste may change it. And then as the disease progresses and there's more cognitive impairment, patients may be switched to high energy food supplements, which can be high in sugar. There's also sometimes changes in their medications to improve adherence. And so they may not be taking tablets anymore. They may be relying more heavily on syrup, liquid, or suspension medications, which could impact their dental health. Memantine is a interesting medication. So again, it was trying to decrease early cell death. And so you see in the normal situation, you have appropriate amount of glutamate, which signals to the cell, and excess glutamate is uptaken into other cells for breakdown. What happens with Alzheimer's disease is that the amyloid, beta amyloid, so those plaques and tangles, can inhibit the uptake of glutamate. And so then when you have too much glutamate, then you start to have cell death. And so memantine is blocking that excess glutamate, so it's not causing cell death, is the idea. So just kind of an interesting mechanism of action of how memantine works. Hopefully this can be a quick review slide for you guys. So if you can think about the potential causes for Alzheimer's disease and then our drug targets. So we're thinking of that loss of neurons and our loss of acetylcholine. And so we're going to target increased acetylcholine, and we're going to target avoiding cell death. And next up, we have Parkinson's disease. So like dementia, it is a chronic progressive degenerative disease in the central nervous system. For Parkinson's disease, we are losing dopaminergic neurons. So you'll see the medications that we use are trying to balance that and increase dopamine. And we also have potentially an excess of acetylcholine, and that results in motor dysfunction. So basically they're in balance. And so once we lose dopamine, our acetylcholine goes up, and now that balance is no longer there. And now we can have the motor symptoms or the clinical symptoms of Parkinson's disease. And those are referred to as TRAP. So patients will have a tremor at rest. They may have rigidity, akinesia, and bradykinesia, so absence or slowness of movement. And they'll also have a postural instability or poor balance. And sometimes this is also seen as a shuffling gait. As the disease progresses, patients can also have dysphagia or difficulty swallowing. They have difficulty chewing. They can have increased saliva or dry mouth, depending on their autonomic dysfunction, as well as their medications. So something to consider for these patients, similar to our patients with Alzheimer's disease. As you can see, this is highlighting very similar to dementia, that there is a preclinical or early symptoms of Parkinson's disease, and these can occur years before the patient may have any of the motor symptoms. The disease then progresses from early Parkinson's disease to advanced Parkinson's disease. And as the disease progresses, then similar to patients living with dementia, is that they may need advanced care due to their inability to perform activities of daily living. Our drug therapy targets for Parkinson's disease are, again, to increase dopamine. So our gold standard is levodopa, which is our dopamine precursor. So you'll see it at the bottom there. You have L-DOPA, and as I mentioned earlier, it's always given with carbidopa, and this is to block the breakdown of L-DOPA to dopamine in the periphery, or when you take it in your GI. And so the L-DOPA can then cross the blood-brain barrier. Once it crosses the blood-brain barrier, then it's perfectly okay for it to be broken down into dopamine, because that's what we want. And so then we have extra dopamine to reduce some of those motor complications seen with Parkinson's disease. We also have the dopamine agonists, so they are pramipexole and ropinirole. So these are going to work like dopamine on the dopamine receptors. We also have some agents that reduce the breakdown of dopamine. So this is enhancing the dopamine that's still available for the patient. So we have COMT inhibitors. So we have entacapone. We also have tolcapone that's not used. So we'll just focus on entacapone. And then we also have MAOB inhibitors. So they block the breakdown of dopamine within the brain. So this is salicyline and residuline. Then we also have the carbidopa, again, to reduce the breakdown of dopamine precursors. And to block that excess acetylcholine that can happen when we have the out of balance dopamine and acetylcholine, we use some of our anticholinergics. For levodopa, carbidopa, as I mentioned, it's converted to dopamine. Carbidopa is to prevent the breakdown. This medication can cause dry mouth. They also can have changes in taste. They can have difficulty swallowing. And we still are going to be worried about orthostatic hypotension for patients on this medication. So again, if they've been leaned back in the chair or sitting for a long time, they'll want to be really cautious when they go to stand up. Dopamine agonists, pramipexole or ropinirole, again, they're going to act just like dopamine in the brain. They have very similar side effects as the levodopa, because again, they're having the same action as dopamine. So we've got dry mouth, they can have dysphagia, that orthostatic hypotension are all going to be a concern for patients on dopamine agonists. The two MAOB inhibitors, the salicyline and residuline, again, you see that they are breaking down, or they're stopping the breakdown of dopamine in the brain. So we're getting more of the patient's dopamine is able to act. So again, the dry mouth, and then they can also have the decreased saliva production, which can contribute to dental. For COMT inhibitors, as mentioned, they're going to, again, reduce the breakdown, decrease the breakdown of dopamine. The entacapone is also always given with levodopa, carbidopa, because it's going to work in the periphery. And so patients, similar to the other medications, that dry mouth and orthostatic hypotension. Our anticholinergic medications, these are going to mainly help with tremor for patients. So they are most commonly used early in the disease process. And that's also related to, as patients get older, these medications can have more risks for falls and other concerns in our older adult patients. So they're going to block the excess acetylcholine in the brain. The most common one you see used is benztropine or cogentin. And the biggest concern for dental health would be the dry mouth, which can be very, very severe with this medication. Again, for these agents, hopefully for our potential cause of Parkinson's disease is that reduced dopamine, which can lead to increased acetylcholine. So our drug targets are to mimic dopamine and block acetylcholine. And next up is seizure disorders or epilepsy. So seizures are that wave of abnormal activity in the brain. These can be seen as convulsions, involuntary contractions, drooling, tongue biting. A person is diagnosed with epilepsy once they've had repeated seizures. So one of the most common medications for seizures that have important dental implications is phenytoin and carbamazepine and valproic acid. As you can see, the incidence of seizures kind of has a U-shaped. So peds have an increased incidence of seizures, and a lot of that can be related to those febrile seizures. Then as people age, less common. And then as we get older, increased risk of seizures, which can be due to tumors. Post-stroke, patients can have seizures, as well as in dementia. There's common seizure types. So partial seizures are when there's only one part of the brain that's affected. And these can be simple or complex. And then there's generalized seizures, and that's going to affect the entire cortex. And then patients can have absence seizures, which have impaired consciousness, staring, eye blinking. These are common in kids. There's atonic, which they have an abrupt loss of muscle tone. Myoclonic, which is the jerking, sudden jerking of arms and legs. And then the tonic-clonic, where they're having loss of consciousness and that jerking of arms and legs. So the ones that are frequently shown in movies and television shows are the clinical generalized tonic-clonic seizures. Patients with seizure disorders or epilepsy, they can have increased risk for dental caries, oral trauma, or lacerations, including bite injuries. There's also concerns for medication-induced gingival hyperplasia, bleeding gums, and delayed healing. There's lots of different targets for treating seizures. So you'll see we want to, and they all relate back to that increased excitation in the brain. And so we can block sodium, we can block calcium, and we can block glutamate, which are all kind of excitatory, or we can increase GABA, which is the major inhibitory neurotransmitter in our brain. And so you can see some examples of medications and where they work to target those different areas to stop and prevent seizures. So phenytoin, that is a major concern because there's the gingival hyperplasia that can occur. This medication does require frequent monitoring of drug levels to make sure that they're in the correct range so that the patient is getting benefit and that the levels aren't too high and putting the patient at increased risk of side effects. The gingival hyperplasia does occur within 6 months. And so there is recommendations to encourage professional cleaning and regular dental follow-up. This medication also can cause dry mouth. Carbamazepine, like phenytoin, requires drug levels concern because there is dry mouth, which can be really significant with this medication, as well as severe blood disorders. So this medication can cause aplastic anemia. So this is a medication that, along with the drug levels, there's also frequent checking of their CBC to make sure that they're not at risk for this because it can increase bleeding. Patients can start to have oral ulcerations, and they may be at increased risk of bleeding if they're using in combination with NSAIDs like ibuprofen or naproxen. The other common medication used in seizure disorders can be valproic acid, or divalproex or Depakote. Like the other two, also requires drug levels and can have very similar side effects. So can have gingival hyperplasia, can have the dry mouth, increased bleeding. So just these medications are monitored very closely due to the severe side effects that the patient can have. So the potential causes for seizure disorders are those increase action potentials, increase excitement in the brain. So our drug targets are to decrease those excitatory activities, so calcium, the sodium, the glutamate, and then increase our inhibitory, so things like GABA. And last up would be neuropathic pain. So this is nerve pain. This can be from a variety of different reasons. So patients with diabetes, a long-term complication, can be damage to the nerves, which can cause this nerve pain. Also fibromyalgia or shingles, which is the reactivation of the chickenpox virus for older adults. So patients with nerve pain, they're going to complain of like burnings, shooting, pain. For patients with diabetes, this can frequently occur in their feet. But it can be anywhere for patients with fibromyalgia or shingles. And the two medications we'll talk about are gabapentin and pregabalin. Gabapentin, this is a medication, if you do see it on people's medication list, you might see very high doses, and that's okay. Also, this medication can be used for lots of other reasons. So patients may be on it for anxiety, they might be on it for seizures, they might be on it for restless legs. So just lots of reasons that people take this medication. So it's a common one to see on medication lists. And patients will have dry mouth and dizziness with this medication. Other one that is very similar would be pregabalin or Lyrica. So again, like gabapentin, used for a variety of other reasons and has very common dental considerations like the gabapentin with the dry mouth and the dizziness. So the potential cause for neuropathic pain is damage of the neurons, and so our drugs are pregabalin and gabapentin. And so hopefully this is a quick review for you guys to be sure you can identify medications to treat the 4 conditions we talked about, so epilepsy, neuropathic pain, Parkinson's, and Alzheimer's disease, and hopefully identify the common adverse effects and some specific oral implications associated with these medications. And thank you.
Okay. Why isn't it going away? Okay, you guys are good to go unless you have a question. Goodbye, good luck.